First technique is you can pass a number 8 Higgins dilator through the cervix, and if there is no resistance for both inserting and for pulling out, then you can be sure that there is a chance of cervical incompetence in the future. And another option is you can insert a Foley's catheter, say size 16 Foley's catheter, okay, and you can insert this with 1 ml of saline or whatever, okay, say saline. So, if you are able to pull this Foley's catheter with 1 ml of saline within the bulb without any resistance, okay, again you can make a diagnosis of cervical incompetence. But remember, we are not doing this regularly and it is not that much reliable also, okay. Now, we will see the management part, okay. Management part will be doing cervical encirclage procedure, okay. This can be done during pregnancy or when she is not pregnant also, okay. So, during pregnancy and non-pregnant also. First, we will finish this non-pregnant thing. So, the previously used procedure was Benson and Durfee surgery, okay, but we are not using this. And now, the recent surgery what we are doing is lash and lash surgery, but however, a laparoscopic surgery will have good prognosis. Clear? And during pregnancy, the circlage what you are doing, okay, can have various indications, okay. So, we will see what are the indications of circlage during pregnancy, okay. First one is history indicated circlage. So, that is simple, previous history of second trimester loss, okay. So, you need circlage in this pregnancy. And the second indication is ultrasound indicated, okay. So, that means in the second trimester we are seeing ultrasound findings what we have seen so far, okay, in the second trimester, and because of this you are offering the women a cervical circlage. And the third indication is a physical examination indicated or clinical examination, as we have seen. Sometimes, as we have already seen, the woman can present with cervical incompetence and there can be opening up of the cervix, bulging of the membranes, okay, everything. So, in that case, when you see it clinically, okay, clinically the patient presents with dilatation and effacement of the cervix, okay. And next indication is a emergency indicated circlage, okay. The patient presents in emergency with pains and bulging up of the membranes, okay. Patient presents in emergency. Now, if you take circlage, it can be divided into the ways in which it can be performed, okay. Some circlages can be performed transcervically, that is transcervical circlage, and we can even offer a transabdominal circlage, okay. However, transcervical is the most commonly done one, okay. We have McDonald's surgery, okay. This is the most commonly done surgery, okay, followed by Shirodkar's operation and worm stitch, okay. So, we will see a McDonald's surgery first. See, this is the most simple and preferred procedure, okay. You can give regional anesthesia Okay. Woman is placed in a dorsal lithotomy position. Vaginal and perineal cleaning and draping done. Okay. Don't forget to drain the bladder. Okay. What you will do is, you will hold the lips of the cervix with the sponge holding forceps. Okay. Okay. Until this, I hope there is no confusion. So what you will do is, you will hold the lips of the cervix with a sponge holding forceps. Then you should use a non-absorbable suture. Okay. And with that, you will be taking the stitches in a purse string method. Okay. Purse string method means, for example, if there is a cervix like this, okay, I'll be taking my first stitch at 2 o'clock position. I'll be going to the 10 o'clock position. Then again, I'll be coming, repeat. Purse string method means, suppose this is the cervix, okay, that I am seeing through the perispeculum examination. Now, how I will take my stitches means, I will start at 2 o'clock position, okay, and go to the 10 o'clock position, then come back again at 8 o'clock position and come back again at 4 o'clock position and complete the stitch, and I will place the knot either anteriorly or posteriorly. Clear? Okay. So, what we have done till now? We are going to take a purse string suture. Okay, that was applied around the cervix. Okay, we used a what kind of suture? It is a non-absorbable synthetic suture. Example, Prolene. Okay, and we placed the knot. Either you can place it anteriorly or posteriorly. Now we will see the Shirodka stitch. See, this is usually done when McDonald's cannot be offered or McDonald's stitch failed. Okay. What we will be doing Shirodka stitches, we will be placing the stitch at a higher level. So, we will be doing bladder dissection and pushing up of the bladder. Okay. The stitch will be usually placed at the level of internal cervical os. Okay. Stitch at the level of internal cervical os, and remember, this will be using Mercilin tape for giving suture and a special needle called Shirodka's needle. Clear? Now, worm stitch is usually offered when the woman had presented an emergency. Okay. With bulging up of the membranes. Clear? So, next is about transabdominal circulage. So, this is done when transcervical circulage fails. Okay. Here we will be opening up the abdomen. Okay. We will be doing a short dissection of the vesicouterine space and will be creating the window on either side of the cervix by displacing the uterine vessels, and will be passing a Mercilin tape and will be making a suture at the level of isthmus. Can you understand? Okay. So, this is not needed, just for understanding, okay, completing Just for completion sake we are doing this. Okay. So sutures, important points include sutures are placed at the level of isthmus. Clear? See, this is usually done when you have so much of time to prepare the OT, okay, and there is no repeat. See, these procedures can be done when there is sufficient time to prepare the patient and make the OT ready and all. Okay, suppose if the patient presents in emergency, what you will do? You have to immediately place the patient in the Trendelenburg position. Okay, and you have to insert a Foley's catheter and fill it with 600 ml of saline. Okay, so this distended saline will act as a obstruction, okay, to the bulging membranes and the fetus from not coming out. Can you understand? Yes. Let us see about some contraindications of cervical circlage. Okay. When the cervix is more than 4 cm dilated and when the membranes had already ruptured, okay, or there is presence of any infection or uterine contractions has started and there is profuse bleeding. Okay, in all these cases cervical circlage is contraindicated. Okay, and what are the complications you can expect? There can be chance of hemorrhage, infection, or even chances of preterm labor or premature rupture of membranes can be there. Okay, so usually after giving cervical circlage, this can be removed around some 37 to 38 weeks. Okay, and to prevent this preterm labor risk, we can even supplement them with progesterone. Clear? Okay. Now we will see some endocrine factors. Endocrine factors that can lead to recurrent pregnancy loss include definitely a poorly controlled diabetes mellitus. Okay, you should check HbA1c for this, and HbA1c level ideally should be less than 5.7% if she is planning pregnancy. Okay, and in case of poorly controlled thyroid function also recurrent pregnancy loss can happen. Okay, especially overt hypothyroidism or a hypothyroidism. Okay, this is a specific risk. Okay, and how you can manage these disorders? You can give preconceptional counseling. Okay, and not only this, PCOD where there is hyperandrogenemia and hyperinsulinemia. And not only this, PCOD where there is hyperinsulinemia or hyperandrogenemia is there. So here insulin resistance is present, right? So that can lead to recurrent pregnancy loss. Yeah. Next one I want to discuss about immunological factors. Okay. In that comes the APLA syndrome. Okay. That is, these are a family of antibodies, okay, that bind to phospholipid binding proteins. okay, that are expressed on endothelial cells, okay, and one of the most common causes SLE. Now we will see what is the mechanism that it will be causing recurrent pregnancy loss, okay. Number 1, there is inhibition of the trophoblastic function and differentiation, okay. And there is activation of the complement pathways, okay, at the maternal fetal interface. What do you think it will result in? It will result in a inflammatory condition, okay, and there is also thrombosis of the uteroplacental vasculature, so blood supply is also affected, okay. So to diagnose this syndrome, we have a special criteria called as Sapporo criteria, okay. We will see what are the components of this criteria. We have clinical criteria, okay, where we will be discussing the pregnancy morbidity, okay. So number 1, one or more death of a normal fetus after or equal to 10 weeks of gestational age, clear. And second one, there is one or more premature births or preterm deliveries less than or equal to 34 weeks, clear. And next one is more than or equal to 3 consecutive abortions that has taken place less than 10 weeks, okay, with other causes ruled out, okay. So these are the clinical criteria, okay. And also, as we have seen, there can be vascular thrombosis also, okay. There can be arterial or venous thrombosis, okay. And next set of criteria is a laboratory criteria, okay, where we will be having antibodies, okay. The antibodies include anti-cardiolipin antibodies, can be IgG or IgM, and next one is lupus anticoagulant, okay, and next one is anti-beta 2 glycoprotein 1, and this can also be a IgG or IgM, okay. Simply you can keep in if you have a mnemonic, it will be easy, so you can keep it as LBC, okay. So it is lupus anticoagulant, then anti-beta 2 glycoprotein and anti-cardiolipin antibody, clear. So to define APLA, you should have one clinical criteria and one lab criteria at least, clear. See, management is usually started after confirmation of the pregnancy, okay. So what you will do is, at least after positive UPT, you have to start giving them low dose aspirin as well as low dose heparin, okay. Low dose aspirin means at a dose of 70 to 150 milligram per day, and remember giving heparin is also very important. Okay, and heparin should be started ideally after confirming that it is an intrauterine pregnancy. Clear? And heparin, for example, you can give enoxaparin at a dose of 400 milligram subcutaneously OD. Clear? Because this heparin is going to prevent the thrombotic events at the uteroplacental surface. Clear? So, giving heparin is also important. Okay. We will see some inherited thrombophilias also. So, that include factor V Leiden mutation, deficiency of protein C, protein S and antithrombin 3, then hyperhomocystinemia, then prothrombin gene mutation. Okay. See, all these can be associated with venous thromboembolism. Okay. Now, finally, I want to discuss about the investigations that we want to do in RPL. Okay, very important. So, investigations in RPL. Okay. First one, we can offer them a genetic testing by doing a parental karyotyping, right? Then anatomical evaluation by doing ultrasound, if needed hysterosalpingography or saline infusion sonography or even hysteroscopy. Next is endocrine. Definitely we are going to test for thyroid disorders. Okay, you can check TSH, okay, and check for insulin resistance, okay, and HbA1c. And remember, in case of hyperprolactinemia, if the patient is not symptomatic, no need to offer any investigations, okay, and even anti-thyroid-antibodies also. And next one is for autoimmune causes. Already we have seen, we will be offering anti-cardiolipin antibody, lupus anticoagulant, okay, and we have seen the other conditions also, like if there is factor V Leiden, you can even check for the levels of homocysteine, prothrombin gene, okay. See, what is not recommended routinely? This includes ovarian reserve testing, then screening for infections, okay, that is doing your torch panel, okay. If you see, infections can be associated with sporadic losses, okay, but not definitely with recurrent pregnancy loss. So, do not offer torch panel if there is a history of recurrent pregnancy loss, okay. Then screening for thrombophilias, not routinely offered, okay, and sometimes prolactin testing also not recommended. in the absence of hyperprolactinemia. Okay. Suppose if there is hyperprolactinemia, you can offer the prolactin testing. Okay. And remember, giving folic acid prevents neural tube defects but not recurrent pregnancy loss. Clear? And multivitamin supplements or progesterone also doesn't improve RPL and doesn't increase the risk, And remember, multivitamin supplements or progesterone are also not going to increase the risk of They are not going to improve the live births in people with RPL. Another important thing I wanted to tell is, women with unexplained causes of RPL, okay, they are there, right? So, they can have excellent prognosis when they are treated with tender loving care. Okay, and this is proved in 75% of the cases without any treatment. Okay, tender loving care alone will work out. Okay, and we have to see about the male factors also. Okay, so first we have to assess their lifestyle factors, including smoking, alcohol, exercise pattern and body weight. Okay, and there is a factor called sperm DNA fragmentation factor. Okay, so assessing this can also help if there is a chance of RPL due to male factor, and if STF is more than 30, then it can be associated with RPL significantly. Okay, and it is seen in 80% of the cases. Okay, so with this we are finishing the discussion on recurrent pregnancy loss. I know this is a vast topic, but I have made it simple as much as I can. Okay, do revise it and do read it and again and again. Okay, so until we meet in the next video, take care, happy learning and bye bye.